Scoliosis. What is it? Scoliosis is a lateral curvature of the spine that cannot be fully corrected. The mobility of the spine is reduced in the affected area, which generally prevents the spine from actively straightening. Such lateral curvature is combined with twisting of the vertebral bodies and adjacent ribs, resulting in a rib hump or lumbar bulge. This is also seen in this picture. A 14-year-old female patient during a growth spurt with a right-sided deviation in the thoracic region. Note the asymmetry of the waist and the rib hump on the right side. Since this deformity cannot be completely corrected, it meets the definition of scoliosis, which is described as a partially stiffened lateral curvature of the spine. The patient in the picture has a Cobb curve of 43 degrees in the thoracic region. On the right, oblique view of a scoliosis model with the same curve pattern showing the three-dimensional deformity. Scoliosis without this type of deformity is not strictly scoliosis. Scoliosis can have many different causes. There are scoliosis due to nerve and muscle disorders, metabolic disorders, and congenital scoliosis in which the vertebra and ribs do not develop properly. Most cases of scoliosis have causes that are not clearly defined. Although many scientists have attempted to discover the cause of the so-called idiopathic scoliosis, decades of research have not yielded a definitive answer. Since the majority of scoliosis patients requiring treatment have idiopathic scoliosis, we will limit our discussion to this type of scoliosis. Idiopathic scoliosis occurs and progresses mainly during periods of increased skeletal growth, during the first 5 years of life, and during the pubertal growth spurt in the most affected girls between the ages of 10 and 14. Scoliosis that occurs during the first 4 years of life is called infantile idiopathic scoliosis. Scoliosis that develops between the 4th and 9th years of life is called juvenile idiopathic scoliosis or early onset scoliosis. Scoliosis that occurs between the ages of 10 and 14 is called adolescent idiopathic scoliosis, AIS, or late onset idiopathic scoliosis. AIS accounts for 80 to 90% of all scoliosis cases. Let us look at the cause of untreated idiopathic scoliosis. The earlier the onset of idiopathic scoliosis, the worse the prognosis. If left untreated, early onset idiopathic scoliosis rarely exceeds 120 degrees, while late onset adolescent idiopathic scoliosis rarely exceeds 80 degrees, which virtually eliminates the possibility of serious cardiovascular compromise. There are various forms of scoliosis that can be broadly categorized as thoracic, lumbar, thoracolumbar, or S-shaped curves, which we also refer to as double major scoliosis. Age, onset of menstruation or voice break, signs of skeletal maturity that the doctor can see on the X-ray, the severity of the curve, gender and the shape of the curve are considered to be the 6 main factors that allow the doctor to assess whether the curve is likely to get worse. In addition, it can be assumed that the risk of curve progression is greater in younger patients than in those approaching adulthood. This is understandable when we consider that during periods of fast spinal growth, wedge-shaped vertebrae will continue to mature in a wedge shape because they are asymmetrically stressed and strained. Once growth is complete, such rapid deterioration is no longer possible. According to a recent review, late-onset idiopathic scoliosis, or AIS, can be considered benign, although spine surgeons may dramatize this type of scoliosis in some presentations. Let us now focus on the course of treated idiopathic scoliosis. Danielsen and colleagues have summarized the long-term results of scoliosis treatment with bracing and surgery. According to these study results, both surgical and non-surgical scoliosis patients can expect to have mobility limitations, a generally poorer health status, and somewhat more pain than people without scoliosis. Since the authors did not find any significant difference between surgical and non-surgical scoliosis patients in terms of health-related adverse effects, the question arises as to whether or not surgery leads to an improvement in the health status of scoliosis patients. Both surgically and conservatively treated scoliosis patients had adverse effects on their social activities, with surgically treated patients being comparatively less able to participate in sports activities, and this group also reported an increased fear of injury. There are more signs of wear or degeneration visible on X-rays in the treated scoliosis patients than in the control group without scoliosis. But the frequency, not severity, is the same in the surgically and conservatively treated patients. In adolescent idiopathic scoliosis, no differences were found in the lungs or lung function between patients treated surgically and conservatively. We know that scoliosis surgery does not have a positive impact on the patient's health, so this treatment is not indicated for health reasons alone. Even cosmetic improvements after surgery are not always permanent. Since a rib hump can reappear within 12 months of surgery and the long-term risks of surgery are unknown, the low-risk option of improving physical appearance with an appropriate brace should be tried first. After all, significant cosmetic improvements can be achieved with modern braces. However, as with surgery, the long-term stability of these strategies is unknown. Recent systematic reviews and the Cochrane review clearly show that according to current scientific literature, there is no evidence to support spinal fusion surgery. Health-related signs and symptoms of scoliosis do not appear to be improved by spinal fusion surgery, so evidence-based, high-quality conservative measures must be used first. More information can be found in the Scoliosis Guide for patients and families, shown here on the left, and in the short Best Practice Academy textbook, shown on the right. You can download both books for free. Please use the QR code below.